that we have about 305 in the ICU for COVID, and then 139 on the ventilator. Interesting to note that our death rate is about 0.4%. This is also from the MOH website. Yesterday's our current R value was 0.99, and if you these are forecasts, and if we are at 1.1, you could see that by somewhere in late May, we probably have about 8,000 to 9,000 cases, new cases per day. We hope that we're going to flatten the curve with all our MCO measures. Okay, where in terms of our local data, I'm just going to quote this paper by our ID group, where they were looking at data from the patients, COVID patients from 1st February up to end of May. I'm just going to kind of highlight where we are in terms of ICU beds requirements. So out of that patients, that the data that they collected, only 3.3% required intensive care beds. If you look at mortality worldwide, there are a few papers published. The one above was in June, and the one below was actually quite recent, sometime early this month. This was actually, the first paper was about 10,000 patients, and the mortality was about 41%. And they collected further data, about 45,000 patients, and the mortality, surprisingly, I wouldn't say surprisingly, but I guess with better evidence, the mortality has dropped further. I did ask around whether Malaysia has had any mortality data. I did, I contacted a few of the MSIC intensivists. Apparently, there's not much official data. But yesterday, Dr. Nazraini from Keluang was submitting an article for Berita Anesthesiology, and in that article, they collected data. This is for Keluang, which is one of the HEBHK, one of the 2 designated COVID hospitals in Malaysia. And you could see here that over that 3-month period, the mortality is 15%. So we're of ICU patients. This is not of total patients. So we are doing pretty well, actually. So what about, if our numbers are right now, we probably are not doing too bad. But what if our R value is more than 1.1? So we may face a tsunami. These are the images that we see usually in the middle of last year. This was actually in Italy. It was actually patients in an emergency department in northern Italy, where they were put on helmet CPAP as a form of non-invasive ventilations. This is because the ICUs were full then. But the good thing is that they publicize this, and we other parts of the world realized that they were actually in dire straits. This is a recent photograph that was shared to me in one of the busy Klang Valley EDs. This is actually SARI patients, waiting for results and waiting to be admitted to the SARI ward or even to the ICU. So what I'm trying to put forward is that our EDs are also busy with the COVID patients. They may not be Cat 4 or Cat 5, but they are probably Cat 3 at this point. Recently, this was actually a BBC report sometime middle of last month that was showing that in 10 NHS trusts, the ICU occupancy was full. And just a fact down below, they had 5,500 beds, and around this time, and on the 10th of January, they were using about more than 80% of their capacity. So I don't have NOH data at the moment, but I presume based on a few of the statements coming out from our government. For example, this one was in January 11, and they were quoting data, for example, 100% capacity ICU being used up in KL, in Kuala Lumpur HKL, as well as in UMMC. And in Sungai Buloh at that point in time was 83%. The day after that, he announced the emergency. And this was a few days back. Again, the same headlines, healthcare system reaching breaking point. But just to highlight below that, at this point in time, he announced the private hospitals was providing 1,344 beds and including 65 ICU beds. So just to recap where we are in terms of bed, I think Azmizi mentioned, but this is actually data just specific to KKM. And out of 200 odd patients, 200 odd private hospitals, 96 has pledged beds, 1334, and of this 65 is actually ICU beds. So if you look at where we are in terms of our numbers is about 1 in 100,000 population. We are well behind India in terms of ICU bed capacity. I know that not all hospitals are built equal. Some would have the appropriate infrastructure to deal with infectious disease outbreak. Some would probably have, I would say, an aging workforce, which may involve issues in terms of possible, I would say, or higher risks of getting COVID-19, and as well as there are different, I would say, experiences in dealing with critical care. Some I know, for example, some of the bigger hospitals in Klang Valley would have intensivists in their file and rank. So, but if we, ponder all this, for those who are able to actually help, I think we should, look into ourselves and look into and ask our conscience whether if we can help. I think we should. I'm just going to quote Martin Luther King. There comes a time when one must take a position that is neither safe nor politic nor popular, but he must take it because conscience tells him it is right. In the past, before COVID-19, we were always behind. This just quoting some of the titles of various editorials and articles: the unsung heroes behind the scenes, the silent force behind the scene. But what COVID-19 did was actually push us into the limelight. This was actually a cover of Time magazine, where Time showed 12 frontline heroes, and one of it was Dr. Francesco Mencisi, from an anesthesiologist from northern Italy. So with I would say, fame and fortune comes responsibility. But what we see lacking now is actually the leadership. Even though we want to help, but where are the guiding principles? Who do we ask for help, and so on and so forth? It's probably a bit lacking at the moment. KKM has announced UCC, and I know the Klang Valley has actually implemented this. As far as Johor is concerned, we had some issues when we had patients, and trying to arrange for a transfer and so on in Gleneagles. I don't think we have a UCC yet at the moment. So how is it going to function? It's basically a command center that covers all this, the public, the private. But what in terms with regards to a central command, I believe that for ICU beds particularly, there should be a subunit under the UCC of various regions or state. So basically, what the UCC should perform is actually, the command control with communication, gather the data of the availability of beds, and then arrange for transfer is appropriate, and so on and so forth, rather than being the task being actually left for the private hospitals to do it on their own. This is an interesting tiered staffing strategy by the SCCM, the American group, where there were and this is in times of pandemic where there's limited resource, the lead will be intensivist, and even non-intensivist physicians, and in most of our private hospitals there will be anesthetists who are actually non-intensivists, should have some sort of direction from the lead here. Just to highlight, a few days back, we had a webinar talk by one of my colleagues in Singapore, Dr. Fahim, who's an intensivist and emergency physician, where he was saying one of the plans of the hospital is that to distribute the work even when there is a surge, a capacity surge. So one example is that the intensivist will lead the care in the ICU, and the anesthetist will be the intubator as well as the line setter, and then the physicians will help in the care of the patient. For example, the spine nurses will help in terms of the proning the patient, and so on and so forth. So the healthcare staff, from doctors to nurses, are reassigned and given different roles when actually the pandemic reach a point where the surge, and we are actually at the breaking point. So another important element of a UCC in terms of function is that there can be telecritical care services being provided. It can be in the form of, and that's what most of us are doing anyway. At some point, we asked our nurses to actually show us a video or an image of the ventilator and so on and so forth. So this can be actually the role that the UCC can assume. And finally, triage. If there are overwhelming cases, and I believe we are actually doing this triage. Not all patients should be intubated or offered invasive ventilation, and this triage, whatever tool that we decide to do, should be actually decided at a higher level and basically implemented down to the ground. So this is just to highlight priorities and so on and so forth as an example. Another important point is that this article from BMJ Leader, basically on VUCA, stands for Volatile, Uncertain, Complex, Ambiguous Times. One important thing is always when we implement at our ground level, at least the various private hospitals that we are working in, is always to focus on patients and staff health and safety. And of course, you have to have clear communication, compassion, and so on and so forth. But what it entails is that
sorry, Dr. Sharidan, lost sound. We lost sound.
Can you hear now?
Okay.
Okay. So one of the important, I would say, role given is the MDAC, the medical dental where the management not only decides, but we as clinicians have a role in actually to determine or to advise the management of the role that we should play, and of increasing safety, not just for us, but throughout the hospital for all the healthcare workers. If we can take home two things I would like to, basically the message that I would like to put forward is that do what is right and not what is easy. We need to ask ourselves, what should we do? And finally, I think we should always think of safety. And this is where we as clinicians should not just leave it to the management, but we should drive the management, or we should guide management through committees such as the MDAC. With that, I thank you.
Thank you, Dr. Sharidan. I now call upon the first speaker for the opposition, Dr. Gunalan.
Right. Hi, good morning. Can you use?
Yep.
All right. Can you see my slides?
Okay.
Okay. Can I start?
Can.
Okay, good morning, everyone. My name is Dr. Gunalan. I'm from SGMC, one of the private anesthesiologists in SGMC. And today, basically, I'm just going to be sharing with you why COVID-19 patients shouldn't be managed in a private hospital. This is an opposite view to what Dr. Sharidan and Dr. Mahfiz are saying today. So we have decided to take up this motion, and I would like to share with you some of the points. Basically, what I'm going to do is to give you a bit of background in terms of our involvement during the first and second wave and some of the challenges we faced at that point in time. I'm going to zoom in straight to our third wave, which is currently happening, and some financial aspects of this particular crisis that is a bit of a concern to us. I will focus on the finances, while my esteemed colleague, Dr. Rozaidi, he will be focusing on the ethics around this involvement of the private sectors here. Right. So basically, when we got the call sometime in March 2020, MOH called us to say that, look, there is a surge. We probably may have to expect some kind of involvement from the private sector, and let's have a discussion. At that point in time, basically, we will mainly focus on how to be prepared, how to have this SOPs in place, what are the treatment guidelines and stuff like that. But pretty much at a very early stage, we were roped in, and that is credit to the MOH at that point in time, that they actually took us as a partner in this entire exercise of preparing for the pandemic. And so we were like these group of action characters, the expendables, all are retired or close to retiring action figures. We all felt very pumped up and ready for action in the MOH hospitals. A couple of us with hair challenges like Prof. Rozaidi also volunteered his expert services to us. And we were all gunning ourselves and ready to go, preparing ourselves to be part of the action together with our MOH colleagues. But we slowly realized that at that point in time, after about 2 or 3 months of being there, we had some certain challenges. First of all, we were not able to get long leaves to actually help out with our colleagues there. And another thing, that after we finish our 2 weeks assessments, we will have to be quarantined, because at that point in time, we were not sure about the requirements and who's exposed, who's high risk of exposure at workplace and stuff like that. So the standard advice given to us was some time that you have to be quarantined after you finish your assignments, which in most of our scenarios is made it very difficult for us to actually take part in the volunteer efforts. There's also difficulty in scheduling. There are times when we are free, the MOH side had surplus of medical officers and specialists, so we were not required. And there was also times when there were cases happening at our own workplace that were suddenly booked, and we were initially supposed to go, but now we can't offer our services in the MOH hospitals because we were needed at our own private place. So those are the initial challenges that we faced at that point in time. And bear in mind, a lot of us were actually at that point decided to volunteer our time, and we were not expected to be paid. But the Ministry of Health did come up with some form of arrangement for a contract employment. But again, this was not really feasible for the majority of us because we were all working in at our present workplace, and it was very difficult for us to take 6 months off work to actually come into a contract engagement with the MOH. But thankfully, by the end of the second wave and somewhere close to July, we began to see that the numbers were pretty much manageable, and ICUs generally had patients, but they never exceeded more than 100. In fact, at one point in time, this seems to be like a very distant memory, we had only 4 patients in ICU and only 2 of them were ventilated. This really meant that whatever strategy that was being done by the Ministry of Health at that point in time was working, and working really well. We, on the other hand, the privateers, felt that, look, it seems that we are more productive if we can help to offset the non-COVID cases from within our own private hospitals, instead of us going to the government hospitals and offering our services there. But at that point in time, we decided, look, looks now everything seems to be cool. Let's just go back and continue our lives in the private hospitals. Unfortunately, I know a lot of us are a bit regretful of this period, but the beginning of October to where we are today, the third wave is pretty much feeling more like a tsunami. Our ICUs are at almost 100% capacity in the Klang Valley, and we are hearing strains and challenges to many, both the COVID and the non-COVID in the MOH hospitals at the moment. Of course, this would definitely trigger a lot of angry emotions from everyone. The anger was palpable, and of course, there was various reasons for that. People are getting pissed off with they have to go through another lockdown. At one point in time, they were upset with the government. A few weeks later, they were upset. There was no government to be upset with. No, we had politicians that we were all getting upset with. But the most important thing that I want to focus on is the anger that is directed towards the private doctors, private hospitals, and the insurance companies when it regards to financial matters. And is this justified? Now, when the private doctors were called in, and this time they were called in a very sarcastic fashion in terms of, why aren't you helping out, We felt that this is a very personal thing. And, one of the reasons why many of us felt a little bit chided at this point in time is because many things were not clear. The financial details were very, very sketchy. Now, medical legal is one of the biggest issues that we face in private hospitals. The fear of getting sued is always in the back of our minds, although we have sincere intentions to managing the patients. What about if we fall sick in the time that we are taking care of these patients? Will our medical expenses be taken care of? Who will pay for them? And there are many of us who are actually in a slightly high risk group, diabetes, heart problems, hypertension, and stuff like that. Will we be exempted? Because bear in mind, all of us in private hospitals more or less are independent contractors. We have no work, means there's no income, there is no salary. So what about those who are against taking part in this exercise? Will they be terminated? Also, another question was the implementation of the emergency ordinance, which means that a lot of powers will be given, and we do not know how extensive those powers will be used against people in the private sector as well as hospitals. But having said all that, we knew that, okay, things are quite bad. this is a time for national service, and we will do what is required to do that. But we are not alone here. There's another angle here that you have to look at, which is the angle of the private hospitals. Now, many of us are really not prepared to manage a large-scale pandemic, but we are more than capable to manage non-COVID cases. There's no issues at all to do that. Now, if you want to do a response similar to at the Sungai Buloh level or HKL level, you have to get our isolation rooms ready. Negative pressure ventilation has to be there. We have to make sure we have adequate Tyvek suits, PAPR, isopods, and also dedicated and trained ICU staffings as well, including medical officers where necessary. Now, the biggest problem is who is going to fund this? Funding has always been a big stumbling block for anything that you want to do in private practice, all right? All private hospital bills has to be taken up by someone. We are not funded by taxpayers' money, all right? If you look at the average, I would break it down to 20% actually pay out of pockets. Another 20% are self-insured from the likes of TNB or Petronas or whatever. But the large majority of patients are actually insured. There's about 50 to 60% who come in with a medical card. And they are the ones who are actually funding their healthcare requirements in the private hospitals. Now, private hospitals, to be honest with you, are extremely expensive to run. To the contrary of a lot of public perception, they are not a cash cow. In fact, we belong in large conglomerates, and we are actually the poorer cousins of all these big conglomerates. Healthcare division doesn't generate a very huge return of investment. If you look at any of the annual reports for the private hospitals, some of these private hospitals have big revenues, 500 million, 600 million. But if you look at the after-tax profit, it's probably around 30 to 40 million. And that's probably less than 10% of the investment that is put in as well. No? So it's not really a big ROI for conglomerates. Now, what about the insurance industry? That is actually getting a lot of flack because of these issues. Now, PIAM, which is the General Insurance Association, they came up with a statement a few weeks ago to say that medical and health policies do not provide cover. And there are reasons for this. If you include pandemic, which is a rare event, it happens once in 100 years or so, you are actually putting in a very high risk exposure, which in turn will mean that the premiums that you have to charge for all your patients will be inappropriately high, and making the affordability and accessibility to insurance products to be beyond the capability of the average Joe in the street. The other issue here is you do not know much about COVID at the moment. We need data to predict costs. And there is also an impact of long-term issues such as long COVID that we are only beginning to find out at the moment. So it's very difficult for the actuaries to predict what is the data that is required for them to price their products. Now, this is a very busy slide, but I'm just going to zoom in straight to one figure here. Let's look at the figure in 2019. What did the life insurance industry generate as premiums? They had close to 38 billion premium collected, out of which 10 billion was investment income, another 10 billion was profit from sale of assets. So altogether, they have roughly about 58 billion in income in 2019. But just focus on the 38 billion of income from premiums. What did they pay out? They pay out close to 38 billion as well. 25 billion was from the policy benefits, agencies and management expenses, another 7 billion, and they had losses as well. So in other words, what they collected in premiums was more or less spent. 38 billion in and almost 37 billion out. So it's a very precarious fine line that they're dealing with. And if you look into it in detail, this represents almost 12 billion in terms of total claims payout. If you look at the red arrow, 5 billion ringgit was spent for the medical expenses in private hospitals alone. 5 billion is a huge amount of money, right? So the life insurance industry is like a goose, okay? If the public, the consumer associations and the government puts on more strains to the goose that is currently laying the eggs, and these eggs are paying for the cardiovascular problem, respiratory, onco, trauma, surgery, the eggs will just crack under all this pressure. And there's fundamentals, without understanding them, you'll be killing the goose that is laying the eggs. So you've got to be very clear on what you're actually asking the insurance industry to do. At the present moment in time, the private healthcare is already helping MOH because 30 to 40% of the population is seeking treatment at our private hospitals, right? If this number goes to the government hospital, you can imagine what's going to happen there at this present moment in time. I mentioned earlier, 5 billion is what the insurance industry has spent. If you look at the MOH budget for 2021, they set aside 32 billion. So in other words, almost 20% of the MOH budget is actually taken up by the private insurance industry. And that's a huge sum. So expectation for the industry to do more when pandemic is never been accounted for in the calculation of premium is not fair. What I'm trying to say is the COVID patients who are admitted in private hospital, they need to have their expenses taken care by the government and not for them to pay out of their pockets. In other words, when the government is saying we are at war, yes, we are at war, but we have to be fair to the patients and the public. You're telling us to fight, but you have to buy your own guns and bombs to defend yourself. And I think that is absolutely wrong. I had another slide that is quickly going to show you the disparity between private healthcare and MOH. Now, there was a question asked in Parliament about a year ago. What was the cost of taking care of a COVID-4, Category 4, Category 5 patient in an ICU? The answer was for a 21-day period at a cost of 870 ringgit, the actual cost to manage a patient was about 18,000 ringgit for every patient in ICU. Now, when you compare that to a private hospital, we have some studies done, and this was a study that I took from a tertiary hospital in Klang Valley, where they focused on about 3,000 patients and about 300 cases were identified as high cost group, similar to the group that you're talking about for Category 4 and 5. And they had close to $20,000, which is about 100,000 ringgit in terms of expenses. So 18,000 compared to 100,000, MOH can actually manage 4 ICU COVID patients for the cost of 1 in a private hospital. So that is a significant amount that if you want to compare apple to apple, no? But it is quite a big difference. So what shall we say is the current government strategy? They have allocated 100 million, well and good. As of a few days ago, Prime Minister has informed that 27 million is going to be spent to partially outsource treatment of non-COVID patients to private hospitals. We are saying the above is only part of the solution. What we are asking for, allocate more funds for COVID-19, non-COVID-19 cases to the private hospital, while the full force of the MOH from the financial and the human resources is to be capitalized for COVID-19 response. So in summary, I'd like to end my speech by saying that I do not agree to manage patients in private hospital when no one is prepared to take the bill. I do not agree for patients to have out-of-pocket payments for their expenses in private hospital, which is completely a government responsibility in my view. I feel that the government should outsource more non-COVID work to the private hospitals, and I also feel that COVID-19 patients are best managed from a financial angle in the Ministry of Health Hospitals. And I have to like to reiterate again, this is not a me versus them situation, yeah? This is us in this together. Thank you very much.
Thank you very much, Dr. Gunalan. Please welcome the second proponent, Dr. Mahfizral. Dr. Mahfiz.
Okay, everybody can hear me clearly, yeah? Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi taala wabarakatuh. And a very good morning to Chairperson Sir, my esteemed colleagues, both Dr. Shah, Dr. Guna, and Prof. Rozaidi. As here we are today in our spectacle of different kind of webinar, or you could say a mild debate, or even a mild proposing and opposing to the topic that we have today, to COVID or not to COVID. That is the question. To where I put to COVID and to not to COVID is the answer. And the answer lies within. Well, as we can see from what the topic that we have here is in terms of we talk about our own private hospitals capacity and our what we can do in this current pandemic that the government is having. And as we can see, being uttered again and again by the highest authority of the country, that we are at a stage, the healthcare is at its maximum. I mean, that is the claim. And of course, us as anesthetists, we are always who we are. We chose this we choose this career because it fits of how we do. We are cautious, some super cautious, but of course it's always for the safety of the patient. We like to be out of the limelight. We like to be the silent ones. We like to be the one who's not visible. But I think it is time now that we make ourselves visible. It is time now that we take this into more consideration, because why? We are the last line of defense. Hence, when this comes to our country, and again, of course, what we do, so in a Malay proverb, we put it as bujur lalu melintang patah. Or in English, bring it on. All right, ladies and gentlemen. Okay, thank you, Guna. I think your slide is your slides and your debates or your points are very clear on why as such. And I guess that opinion holds, because their issues should be addressed and be clear to all who are there. Because now we are in the area where we are drawn in darurat, our emergency. And with this emergency, there are a number of implications that we ourselves not sure what are we to do and where we are going. All right. The emergency as well as the healthcare worry is on the keyword of ICU search. At the moment, that is one of the issue. We talk about, we are not talking about the whole pandemic, where when the pandemic, when COVID-19 came and we managed the second wave, the third wave is coming. I would say that currently our public health measures has gone wayward, that we are bottlenecking it at the critical care. A month ago, on the 6th of January, our ICU take-up was 144. Today, or yesterday, it's already 304 at a maximum of 322. But take note that 139 ventilator is the highest ever number that the ICU is taking care at the moment. And I think a press conference given by the DG telling that in private, yes, we are at, now it's not to say COVID, we don't want or we don't want. We have to, and we are doing. And I applaud my colleagues out there, especially in the Klang Valley. There are now 7 intubated patients. This is DG, not me, saying, and 24 we're being taken care in ICU. So we are taking care of these patients at the moment. And again, as I mentioned, the keyword here is ICU search. We are at this stage where the capacity of ICU is overwhelmed. KKM is overwhelmed. Klang Valley is overwhelmed. 100%. UM at one time, you took a statistic going about 120%, because pledged bed is a certain number, but they are taking care of ventilated patient more than that number that been given earlier for COVID-19. Here on this slide, I think it is a good reference. We will talk about managing COVID-19 crisis, ICU. This paper actually takes about, and you can use this as a reference in preparation of your own hospital. I do urge for you to take a look at this. All right. In Spain, when they pronounce nationalizing dia, okay, but of course our situation in Malaysia is different. We're not nationalizing, but in Spain, when it was nationalized, the healthcare is nationalized on the 16th of March 2020. By the 21st of March, this particular working paper came out and published in their Enferm Intensiva. And this is their society of all their intensivists or the anesthetic care, taking about their plans of what to do at the different stages. Of course, we are not overwhelmed as how they are, because at that moment of time for them, they saw what happened to Italy. Thousands die per day, and it was happening in Spain. So they were getting ready. They have a plan. And this is where I think in our own fraternity, we must be ready for this, which I do not see at the moment. All right. I mean, that's my critique on this. Yeah. Because we talk about the start of the pandemic, and we are talking, maybe we are arriving to the point of saturation of our ICU bed. And then again, what we talk about the collapse of the ICU bed, what do we do? Where do we go? So different strategies at different times. And this is the contingency plan. Again, a paper that was produced in 2019, and this was talking before COVID. Everybody in the world is predicting there will be one day there's something of this kind of influenza-like pandemic happening. And of course, what was how do ICU should prepare? As you can see, this is the response threshold graph, of which level we are. So where are we now? I would say we are still less than 100%, yes. But what happens next if we get overwhelmed? Our ICU gets full. Now we are talking about we have 500, we prepare about 500 beds plus for COVID. If we fill that up with COVID, are we taking the non-COVID ICU care? Are we going all out? Of course, the total number is 890 beds in the whole of Malaysia, but we have 1,330 plus ventilator. So are we going to expand to such? So this is the plan that should be clear from the top and of course being displayed to the bottom, and of course to us, the ICU anesthesia fraternity, of what we are going to do. Either we are separated in terms of private and government, or directly with the Ministry of Health. So we have to know, because the responses would be different, and we should say we should be ready for that. As mentioned by Dr. Guna previously in his points, yes, I do agree to certain points of what he is saying, and perhaps that would be in the response of where we are now. And the strategy should be look forward. But if it comes later, I don't think that would be the answer, or that would be what, in terms of private, to be ready of what they are expected to do. Okay, with the WHO, WHO actually came up with this particular working paper, which is being developed more than about 1 or 2 years, and talking about engaging the private healthcare service delivery in the mixed healthcare system, just like most of the countries in the world is. And this working paper is being made because of that integration. As interestingly, in non-developed countries, private sector is taking the more of the care for the country compared to the private, I mean, due to obvious reasons. And this is why, and it comes in just timely with what the pandemic happens. And there are certain things in this paper that mention of how this collaboration will actually work in terms of utilization. And I guess this is where in the engagement of the KMKM and us as the private sector to be as such. But of course, of all we're talking about, I think we are stuck at the policy and dialogue somehow. And we are not move forward. There is no possible policy. But at the same time, it should be balanced with the funding and the design of the regulatory framework, or the framework of what has been done. I think Dr. Sharidan, the speaker, mentioned leadership needed. So here, I am proposing in terms of I'm talking just critical care bed or critical care area here. I'm not talking about the MOH level as such, because it covers a lot of things. But at least this small point, and at least something as us in this fraternity can do and should do. We're talking about structural framework, and we talk about financing. These are the two main issues. And again, there's another paper being quoted by when we talk about the action plan in engaging private healthcare services in response to COVID-19 by WHO. These are the 2 points that it is on top, most top to be discussed and to be sorted out, because these are issues. Where do we find the finance to do all this? And second, what will be the framework as such? If I am to be at the top in a different dimension, I think we actually discussed this. Kalau kita macam cerita Avengers lah kan, the multiverse. Alright, what I would suggest truly is a true COVID ICU command center. Yes, the UCC has been proposed, has been shown to us, but that is like 2 weeks ago. Where is the UCC in terms of the function as how it should be now? We talk about the Klang Valley, yes, but UCC is unified command center, which means unified. And I should know. I don't know anything about it. I'm in the south, sorry, and we do not know how it works and where the ICU comes in, where our sense of our ICU beds that we use, or ICU critical care we use in private, who do we send into in terms of to this particular body, who controls it? I reckon we should take charge. Our intensivists, our anesthetists, either KKM or none, but this body should be there, a command center to be given the autonomy, clear leadership role. And this is where to consider which part of the pandemic we are facing, whether we are at our 150%, our 200%, we should be clear. And of course, the transparency on national ICU beds coordination. Questions has been asked. We are using 305, but there are more than that at the moment. So there are still ICU beds not used. So where are they? And how are we? And this is where the command central should be able to determine as well as manage this. I think it is very important. Of course, we talk about policies and guidelines, which is strongly must be there. And currently in KKM, we have our Annex 29 in the COVID-19 particular website. But again, the COVID-19 Annex 29 is fairly general. So it needs to be specific, adapting on the response And in terms of setup, where we are at our stage now, when if it's divided as a hybrid hospital or a designated hospital or a total, what we are going to do later. And again, the consultative clinical management, time-based rounds. I appreciate this so much in terms of getting information. Like now, we are working in silo. I know my colleagues in the in Klang Valley are communicating in silo. Perhaps I think we need a figure on, if not a figure or a body. Just like anybody call Suresh, Datuk Suresh, for I think the whole Malaysia is calling him of how to manage their patient. Penat tu. Of course, you may have that certain reason, but I think in ICU we need to have somebody like that as well that we can go to, and again getting the information. And this is where when we talk about legal framework, we may have help in that sense of we're not doing even though without that expertise. And of course, audit data collection, which has always been our weakness in giving it out. And because until now, despite all data that collect, we still cannot find any literature to say what is our experience, our mortality rate, data directly in ICU. All right. Alamak, jangan panjang sangat. Sorry, yellow card. Hazmizi, kalau ni bagi yellow card or red card, I think dah terlebih time ni. Okay, this is what I mentioned about our ICU bed management unit command central. It complements the UCC. The structure should be there. Okay, this is my proposal. This structure should be there. How we do it? Yes, that is what we should think about. Next, in terms of private, there's only 65 beds that we are going to manage ICU for COVID-19. Hence, I think it should be unified in the sense of it be under a body or this consultative council that we go to, we do our rounds, and the role of this consultative council in terms of guideline policies, the admission criteria. I think admission criteria in the government hospital has changed nowadays. Who we ventilate, but then it's not made official or as such. It's just added capacity when it's maximized. So these are the issue. And of course, we're talking about intellectual discourse for effective standard decision making. So I think that should be clear. All right, this is something that, again, one of the literature that I quoted earlier, how or the policies in terms of when we decide admission or the futile care. So what would it be? Are we going for the first come first serve? Are we going for the greatest good for the greatest number? Less severity first treatment based on our clinical score. So these guidelines should be clear, and this should be laid out to us as well in the private, and this is how we can manage, and we will manage. Because at our current number, we are managing at the moment, but there is no clear guideline in the sense of what to do next in terms of management as a whole, not clinical. Clinical, I think, good. In private, the teamwork between the ID, between the in our anesthetists and intensivists are I think, a very close knit, and this is how they manage daily and how they are all with the outcome to make the patient better, and of course out of ICU. All right. And of course, at nucleus hospital level, this when we talk about infection control, staff protection, staff isolation, this I have shared previously, and this is how, in terms of your working group, in terms of managing your space, your human resource, your supplies, and the systems and standards that should be in. So this is at hospital level, especially when we talk about hybrid hospitals, where there may be challenges. There are challenges, but I guess it has been 1 year since we have had this. There would be some preparations, but in hospital, I would assume, for private hospital, kalau langsung tak, I'm wondering what have you been doing for this 1 year? Because this is there, it's coming there. You must have had your contingency plans. All right. Now we're talking about the financial issue. I'm just going to touch a bit. Currently, the solution, what the solution is there. For February, latest we mentioned 27 million pledge for non-COVID cases going to public from public to the private. All right, good. 18 January, 100 million was pledged. So, I mean, what was there any specific discussion previously? What, where? I think we should stress into this and something that we need to sort this out later, because we need to sort it out in the short time, especially if the surge goes up. We are all crossing our fingers hoping the surge settles down, but will that happen? We don't know. And if we are lucky, it is. But if it is not, then how? And how will these plans go by? The big plan is there. All right, financial issues proposal. We talk about out of pocket. That means the out of pocket for the patients. So in terms of business continuity plan, DG mentioned, the minister mentioned. In terms of we talk about consulates and VIPs, because these are paying patients. So these are where private should come in terms of the critical care bed and the care, because it's definitely a guaranteed hospital revenue, at least 10 days in ICU. 10 days, I quote from the median and mean of studies all over the world, and I think even in our country as well, Malaysia, at least in ICU. So, you know, in terms of when you calculate, so at least there is there. If you talk about survival of the hospital. Because private hospital is an entity where it's a business in a way. Of course, it is focused more on the social responsibility of who they are. But at the same time, if the business is not there, then we have to close the hospital. And if the hospital closes, it gets worse. Everything is pushed to the MOH, 100%. That is something, okay, we talk about designated private hospitals, all right? So this slide is I'm taking currently, if we want to do that, it needs lots of cooperation between the private, which in this short time, we have not planned this earlier, but if we do, this needs to come up. But whether it is possible or not, that I think up to the major players. Some major player may want to make their designated COVID hospital to be there, but then comes to the question, I think Dr. Guna has mentioned, as independent consultants, we are talking about, because we are not employees. So this must be sorted out in terms of the remuneration and how they function. And at the end of the day, the hospital will be designated as COVID ICU hospital. What is their future? Because if in that year they're not doing and making money, then what's next? So I think this is another part of the thinking. And of course, the fund source, are we talking about direct government bailout? How much money can the government give? Industry, GLCs and major players, tax-related reimbursements. So these are things and solutions that can be done. I mean, in our PERMAI, in our previous whatever by the government financial bailouts, and these are the things that maybe one of the models that we can use there. All right, I'm talking here just a short one, talking about our COVID-19 beds in ICU. All right, it is definitely expensive in the sense of how much it is. So I am proposing what we can do, because sometimes these patients, when we have to admit, there is no choice. Or maybe we have to that situation, we come in. So a COVID humanitarian fund. As you know, COVID humanitarian fund is for those who can't afford, but we have to treat, and I think it's a social responsibility. Of course, for the group can come in, but of course, we talk about Islamic social finance, where there is a role there. There is a role where this money, where available social financing can be used in combination with the crowdfunding. It is a workable idea, I must say. It is possible, but yes, against the finite. And of course, the costing would not be governed by the hospital, but by the what we call the case mix DRG, a method of how we actually calculate the expenses, or not expenses, the cost of a particular care. So this is a short idea. What I say is workable. Imagine in the global humanitarian fund of the Red Cross Society has collaborated with MAEPS and supplying 1.2 million zakat to the community in Kenya. So that is because of that kind. And currently with this pandemic, the need is there. I think the issue is there. It's just need to be a whole discussion, and somebody need to take it up. If you're talking about businesses, we're talking about sukuk or wakaf, which is possible, but I think I'm short of time to talk more about this. But yes, crowdfunding, these are issues that how we can help our patients who are admitted to ICU in the private hospital. But again, when we talk in the ICU hospital, currently we are talking only about 65. So this is 65 of our capacity. And I believe in terms of us private, we need to be able to manage this well, this 65, because it's only 65, not 300. So we can do that. Hence, let's move forward and do something. But we have to be prepared, not from our side as the private, but also the government side. Multiple working models must be there, must be clear. Create our own ICU plans, source our funds if we need to, especially in the ICU. Per hospital, 1 ICU or 2 ICU bed only for COVID. And of course, patient outcome, patient safety. This is the way. Thank you very much. Sorry for taking too much time. Thank you.
Thank you, Dr. Mufiq. Now I call upon the second speaker for the opposition, Dr. Syed Rozaidi. Dr. Syed.
Okay, boleh dengar tak?
Hello? Boleh.
Okay, you guys can hear me. Okay, right. Okay, Assalamualaikum, good morning. Now, as you can see, all my Padawans, they're very passionate, and you can see how they scream, they shout, trying to bring their points. Now, I'm going to talk to you in terms of concern of a very senior. Now, some of you guys will put it as all anesthetists intensivists, in this COVID-19 management thing. Now, if you look at all these 5 handsome young men here, you can see, and one robot, of course, there. I obviously fit the typical high-risk healthcare worker. I'm nearly 60 years old. I'm male. My BMI is actually nearing my age itself, And obviously I do minimal exercise, but I do compensate by taking lots and lots of supplements. And of course, the common factor with all 5 of us is this point here. Right, now let me start first by, okay. See, technical error now. Okay, now when we first entered the medical school, when we first started our career, it's been ingrained in our minds that the first principle of medicine is to first do no harm to our patients. When we talk about first doing no harm, this is a quote from the Hippocrates Oath. I will abstain from all international wrongdoing and harm. I will use treatment to help the sick according to my ability and judgment, but I will never use it to injure or wrong them. So when we do no harm, we do no harm to our patients. We try not to do any harm to the other patients in the hospital. And we try to do no harm to the family, to our staff, as well as to ourselves. Now, in the private sector, obviously, as you all most know, it's basically a solo kind of practice, where one physician may be taking care of several patients at any one time. Whereas in the government hospital, it's a whole team practice. You know, you have housemen, medical officers, registrars, specialists, and consultants who are there to help the patient get better. Now, with that in mind, we have to ask ourselves, you know, are we giving our best to our patients and our staff? And are we doing it without unwillingly harming them and others in the process? Now, to answer this question, I'm going to bring you to basically, before you embark on managing COVID-19 or any management for that matter, in terms of your ability to set up something, in terms of your hospital in approaching managing COVID-19 patient, you have to look at ability, capability, capacity, and the competence in managing COVID-19 patient. Now, ability to do some tasks means that you and the hospital can do it, and that you have done it in the past. Ability determines a person's or hospital skill or level of expertise. Basically, it just means that can you do it or not? Do you have the ability to do it? Whereas capability to do a task is the potential to do it. That means basically whether you are able to do the task or the moment or not, that is a different matter altogether. But do you have the capability or the potential to do it sometime in the future? Now, for example, you may not have the ability to manage COVID-19 patients in your hospital at the present moment because of lack of staff, ICU beds, the infrastructure is not ready, you don't have isolation rooms, etc. But give enough time, give enough money, you may be able to do so. And capacity is the ability that exists at the present moment, whereas competence is the ability to do something successfully or efficiently. Now, basically what it is that ability shows your expertise, it shows your skill, it shows the potential, whereas capability shows your potential, which is basically a future tense for both staff and hospital, and capacity is the present tense, what we can and we are doing now. And competence is you becoming actually a Jedi Knight in managing COVID patients. Now, let me get this thing away first. There's a bar actually disturbing my view. Okay, so how and who determines our competency in managing the COVID-19 patient? If you look at ability, capability, and capacity, basically what we're looking at is we're looking at certain, there are bodies out there that's supposed to determine our capability and capacity to become a COVID-19 hospital. NSR actually looks at the individual abilities to manage COVID-19. MOH with the Cawangan Kawalan Amalan Perubatan Swasta actually is a body that actually gives us the license to manage COVID-19 patient. What it does is that basically it's a big book that they bring together with them. It goes to the hospital, it talks to our management, it talks to individual doctors, and it goes through a checklist to see whether we are capable or not in running certain services in the hospital. Of course, there are other bodies that will look into all these things like MSQH and JSA. These are private bodies where we call them to help us in terms of organization, process, and practice. In terms of, sometimes it just freezes the, okay. In terms of competence, obviously, we look at morbidity and mortality rates. We look at our own case mix. You know, can you manage neurosurgical patients? Can you do cardiovascular cases? Can you do cardiothoracic cases? You look at the number of patients and cases that you do per year. And of course, in a private setting, we're looking at profit and loss to the hospital. That shows whether we're competent or not in managing certain diseases, as well as specifically COVID-19 patients. So what is our expectation as doctors when we talk about what does it mean for us as doctors and healthcare workers? Obviously, we want a good outcome. And trying to achieve this good outcome, we do not want to do any harm to our patients. So of course, then we will look at standard of care and good clinical practice in the hope that we're going to get good outcomes. Now, I've tried to look up, I tried to Google it, and looking at our own local literature or the standards. This is the only thing that I found out there, is basically the COVID-19 management guidelines in Malaysia. Now, the recent update was in February, just last week. And of course, the document shared by, a guideline shared by Hospital Sungai Buloh, by Dr. Saiful, as well as Dr. Suresh. They were kind enough to share with us some of the guidelines that Hospital Sungai Buloh is doing. Now, we consider that these are considered the so-called standard of care and good clinical practice. Of course, from social medias, from groups, from webinars, we do get other information that helps us. As you all know, CDC, WHO, and various medical societies and groups have already come up with certain guidelines to help us manage the COVID-19 patient. Now, having this document here is only as good as actually you have to read it, okay? You have to understand it and you have to practice it. There are 44 annex and sections and appendix dealing with anything and everything related to COVID-19. Now, from the case, from this document here, these guidelines, okay? From the case definition of COVID-19 right up to specific guidelines in various subspecialties. You're talking about more than 300 pages, guys, okay? Now you have to take this book, you have to look at these guidelines, and you have to adopt it as best as possible. Now, meaning 12 months of MOH experience in managing COVID-19 is found in these guidelines. And we in the private hospitals must actually learn, adopt, and adapt all of it within a month. Or in the case of PCMC, we had to do it within a week. Okay, it was a fast learning curve. It was, you know, we actually, all of us sat down, all 7 of us sat down, and we started sharing and discussing and trying to figure out what's the best way to adopt good clinical practice. So of course, calls for Saiful, tolong. And he was quite kind enough to share with us some of the guidelines given by Hospital Sungai Buloh. I'm just going to take a small portion of this guideline. Okay, this is Annex 29, Intensive Care Preparedness, Preparedness and Management of COVID-19. It's the first page that I'm going to share with you. Basically, it looks like general planning of your ICU. Now, patients suspected or confirmed with COVID-19 who needs ICU will be kept in an isolation room in the ICU. Now, if you do not have that isolation room in the ICU, you then have to designate an isolation room somewhere else in the hospital. Now, once the capacity of the designated isolation room is reached, and the patient will then be managed in the ICU of that patient. Now, I can honestly tell you, not many private hospitals have isolation rooms, okay? Even their own general ICU might be limited in terms of number, space, and the design. So if we are to bring COVID-19 patients into the general ICU area, what about the non-COVID patients? Don't they deserve the right to be treated equally? How are they going to be managed, you know? Are we going to actually neglect their management? Now, all we're doing is just pressing the bubble. We are managing COVID patients, but at the same time, we're neglecting non-COVID patients. In the end, you're going to have an upsurge of problems with coronary artery disease on the uprise. Diabetic patients are not going to be well controlled, and you may get more mortality from other non-COVID patients, you know. Patients managed in designated isolation room that's not within the ICU will managed by the nursing staff from the intensive care. So now it's not that you can use your so-called normal ward staff to manage this COVID-19 patients. They are asking us to use our own ICU nurses. Obviously, it's going to increase the staff load, duties, and responsibilities. And this may lead to depression, exhaustion, and then mistakes will start occurring in our management of patients, in COVID-19 patients, as well as a non-COVID patient. Obviously, they put in the document that you should have a negative pressure isolation room. Again, it's not easy. Not all hospitals can have it. What we've been trying to do over the last few weeks is trying to convert certain normal rooms into negative pressure room. Now, I'm not sure, it involves a lot of physics, engineering, you know, and I'm not sure whether we're actually doing the right thing. The worst case scenario is that we've done, actually what we've done is actually mess up the whole room, and we may be actually exposing ourselves as the patient and the whole hospital environment to basically COVID-19 virus floating around. And of course, we need coordination. It's a lot involves in coordination of hospital management with the other healthcare professionals to manage both COVID and non-COVID patients. Now, this is easier said than done. If you look at the chain of command, it's not easy. You know, you try to get your you try to get your CEO, or you try to get the so-called the unified command center, or even trying to call up MOH, or even calling up Sungai Buloh. It's not easy, guys. It's actually difficult, and a lot of time is wasted on the phone and trying to call up people in trying to help manage some of these COVID-19 patients. This is a protocol taken from Hospital Sungai Buloh, basically looking at intubation. Now, there's a preparation of, there's an intubation checklist that you have to prepare in Hospital Sungai Buloh. When you want to intubate a patient, basically there are 5 healthcare professionals that are going to be utilized in intubating a patient. 3 of them will be actually doing the intubation, and 2 will be waiting outside to take over the patient once the intubation has been done. Now, the 3 staff that are inside to do with the intubation are: 1, the airway itself. The intubationist is going to be an ICU specialist. He is a senior medical officer or a senior medical officer. There's an ICU specialist that is actually the one going to give the drugs and also monitor the patient as the intubation is going on. And there'll be 1 staff nurse who's there waiting at hand to help out with anything that needs to be helped. Once this patient is intubated, then obviously the outside team or the non-aerosolizing team will come in now to take over the management of the patient. Now, how about in Prince Court? What are we doing? I can tell you there are only 3 people inside the isolation room. There's 1 specialist, usually an old intensivist, who's expendable, who will be there during the intubation. There'll be 1 staff nurse who's going to help me with giving the drugs and also monitor at the same time, and another staff nurse that's going to be hanging around. Now, there's 0 staff waiting outside. Okay, if anything, it's probably one of the cleaners and one of the person from FMB who's going to be waiting outside just to see what's happening. And imagine a code blue scenario. We are going to get into a lot of problems when we talk about any patient who collapses in the hospital, and we are the only one who's there to help them. So coming back to my original question, are we giving our best to our patients and our staff? And are we doing it without unwittingly harming them and others in the process? Remember, first do no harm. Out of all the hospitals that are now involved in COVID-19 treatment, 44 from KKM, 96 from private hospitals, how many actually have the ability and capability and capacity to treat COVID-19 patients? How many are competent to manage COVID-19? Can we reduce the mortality rates that we're seeing now? This was taken, I got this from MySejahtera actually, from the internet. This is looking at mortality rates for the last 1 month. The mortality rates cross over the last 1 year, but I'm just focusing on the month of January. If you look at it, when the 1st January, when this data was collected, we had a mortality rate of 3 in the whole of Malaysia, okay? And a 7-day average of 4 mortality. Within a period of 1 month, it has increased by 3-folds to 12. So why is this increasing? Why the jump in January 2021? Why are we seeing more death in our COVID-19 population? Is it because we have sicker patients now? Is it because we have more virulent virus? Is it that we have our healthcare workers are fatigued, as what the DG has said and what the ministers have said, that we have reached a breaking point? Or is it because of MCO, there's a delay in seeking treatment? Or is it because of the introduction of private and hybrid hospitals? We introduced private hospitals and hybrid hospitals the start of this year. Is this maybe why the reason why mortality is increasing? Now, the dissection, or we need to look at very closely why the patients are dying and where they are dying. So is doing our best just not enough? I think we have to be honest with ourselves. Are we actually doing the right thing to our patients? And are we doing it without causing first to no harm? So let me end here by quoting a few quotes from my good friend, Master Yoda. I'll try and not, of course, I'm not going to try to do it in his voice, but I'll try. Do or do not, there is no try. We just have to do it. If no mistake have you made, yet losing you are a different game you should play. Learn and adapt, guys. To be Jedi, to face the truth and choose, give off light or darkness, Padawan. Be a candle or the night. Now you can be negative about it, you can just bitch about it all day, or you can be positive and take up the challenge. Now the choice is yours. The greatest teacher, failure is. At times you will fail, but you will learn and you will succeed. And with that, I thank you guys.
Thank you very much, Dr. Syed Rozaidi. That's the end of our first round. For the second round, now I open the floor for rebuttal. Maybe Dr. Cha can start first.
Okay, I'd like to direct the questions to Dr. Guna. I think he did mention about the MOH cost in one of the Parliament question and answers, about 18K for the cost of ICU care. And then in comparison, there was a study published about 20,000 USD. So that's really like 5 times the cost. I think the whole the answer that was given at the Parliament was mainly because of the fact that the government, the KKM practices more like a socialist, or communist kind of civil service. So they didn't take into account the real costs of actually the human resource, which is actually the more expensive bit. Would you like to respond, Dr. Guna?
Sure. Thanks for the question, and I think it's similar to one of the
question.
Yeah, attendees. Dr. Kaur has asked the same thing as well. Why is there such a big disparity in the costs between MOH and private? Now, I think very, very important to look here in terms of what was answered in Parliament. We have to accept that as the truth in terms of that is the actual data that was spelled out and mentioned in Parliament. But I think realistically, there are many, many aspects of it which is not being calculated for and accounted for as well. 18,000 is an extremely reasonable amount of money to be spent on a very sick patient in a government hospital or private hospital, if that is the actual figure. Now, are we transparent about that figure being a correct figure? Now, why I'm trying to highlight is we may not actually be getting the right figures there. If you look at the study that I highlighted earlier, that was a study done in a tertiary hospital using a different methodology altogether. They used a case mix DRG, diagnosis related group kind of situation, where not only the cost of the medications, the ICU care, the equipment and whatnot were factored in, they also factored in many other aspects of the care that is involved to the patient, the administrative cost to it, even the marketing, the hospital staff, which is non-medical related. All those are actually equally important in order to run a functioning ICU. So if you ask me, my personal opinion is that the actual cost would be what is spelled out in the study that I mentioned, the 18 to 20,000 US dollar. That would probably be the closest estimate in terms of what actually costs to the government. This is where I think it's very, very important for us, especially those in the government side, to actually highlight, are we undercutting or under-declaring the actual cost? Because it actually is going to affect the way you guys are going to ask for budget in terms of, okay, if I'm going to be spending only 18,000 on a patient and I'm going to have, say, only 10,000 patients a year, versus if I'm going to be spending 100,000 for a patient and I'm going to have, say, 10,000 patients a year, there's almost 5 times the amount of money that you actually need to successfully run an ICU. So if you don't get those numbers right, what you're going to have as a perennial problem, the constant dilemma that you guys face in the MH hospitals, underfunded under-serviced, understaffed, under. Everything will be forever under because of the manner in which the calculation was sent to the leaders that decide on the budgeting will lari a lot like, no? So on the other hand, what we also find a little bit, to me, is a bit vilifying the private sector is that if you can manage somebody for 18,000, hey, then why are you guys charging 100,000 in the private sector? So that is actually a wrong way to take home a message, because in all intent and purpose, the actual cost is actually 100,000 ringgit, and probably the private sector is just marking up maybe another 5 to 10% on top of that to actually make a little bit of return of investment. But if we go around brandishing that actual number, I fear that the public may be a little bit critical of what we in the private sector are trying to do. It is like, hey, 20,000 ringgit versus 100,000 ringgit over there. I mean, that's a huge disparity, and this is like daylight robbery, you know. In other words, how come the private sector is charging that much when it's actually costs only 18,000? So I think the important message here is make sure the calculation that is being done is actually the correct calculation, and I think you need to move towards the case mix and the DRG kind of a calculation so that we have a little bit more accurate estimates in terms of the number that you need to actually allocate for your ICU care. I hope that answers your question, Dr. Shah.
Yes, it did. Thank you very much.
Okay, any more rebuttal? Dr. Mafid? Anything that you want to say?
Well, I think at the end of the day, I'm not really rebuttal, because I believe that all these points are clear. It's just to get these points all together, and I guess that's why we have this debate and forum today, and so that we can have this medium of discussion that we're having now, and to those who are listening to see the viewpoints of where what private, because I guess just like Guna mentioned earlier, we maybe seeing private nak untung or etc. You know, but at the end of the day, it's about how things work and how the complementary roles of private and government. But again, in this current situation, I believe that the plan lah. To me, I go back as an statist. We plan freaks, I must say. And in our whatever we do, we plan. We have our plan A. Plan A doesn't work, then it's plan B, plan C, plan D, and of course all teeth or breaks loose. The situations to be ready and to be considered. So if there is a possibility of a proper direction of what to do and at what stage of resources, I think we are learned. And as Prof. Rozaidi mentioned earlier, then you will learn as we go, and we just have to do it. And especially at this stage, it's like not an option. And if the surge comes in, but if we are not ready, then we are ready to fail. So I guess that will be my.
I would like to add here, you know, we talk about national service, you know, we talk about basically doctors are inclined, we're passionate lots actually, and we are humanitarians at heart, and we actually want to do what's right for our patients, you know, but some things reality do have to be taken into account also, whether what we're doing is actually the right thing or not. And we have to look at our own welfare, our own, you know, health and that kind of thing. But, you know, asking national service, yes, but why limit it to the medical faculty and fraternity? Why not everyone else? Why is the banks not doing their part? Why are the insurance people not doing their part? How about those people who supply the pharmaceutical companies? How about, you know, the glove makers, Top Glove? Have you ever tried to ask Top Glove to give you free gloves to your hospital? We are being charged, and they're making a profit out of it. You can say it's RM1.50. I doubt it, you know. But you see, by right, everybody must do their part. Now, it's not at our level, of course, but once you invoke on the Darurat Akta, you know, rather than come after the hospital, you are coming after we are managing the pandemic in terms, it's a medical, for the pandemic, mind you, it's not just a medical management. We are doing the medical management. pandemic is the whole spectrum that you have been looking at, you know, from the top right down. We are actually at the end of the stick. We are actually, you know, managing the sick, but we want to reduce all the sick from coming to us. This is where I think most of the panelists and most of us have agreed. There are a certain failure on our part, on the government's part, on everybody's part in trying to so-called flatten the curve. I'm sure you all, let's be honest, I'm sure this MCO 3.0 that we are facing now is actually it's a joke compared to the first one. I'm sorry to say it, but it is. I'm seeing people walking around. Okay, nampak tu? Sedap tu kat KLCC ni. People are walking around all over the place there now. Okay. I try to be apolitical, but sometimes it just gets to me, you know, that Indian people are just pushing everything to the doctors. We are being made the scapegoat. We're being made the bad guys, you know, in this whole management of pandemic. We are made to say that we are the money-hungry lots, you know, that kind of thing. When yet there are a lot more other people who can do a lot more stuff, you know, to help with this pandemic.
Any more rebuttal? If no more, we good. Yeah.
Yeah, I just want to add on to what Prof said as well. You know, I think this pandemic, although it's probably going to be a once in our lifetime, hopefully, but I think there are many lessons that we can take from this management of this pandemic moving forward. And I think the main thing is I feel that it's a long time coming, that the public-private partnership has to be much more than just cakap-cakap angin kosong lah. Basically, we need to put our foot down and just say that moving forward, we have to make the public-private partnership work. And that means we have to work towards a proper national healthcare financing scheme where everybody contributes some element. Of course, without having the issues of middlemen and cronyism or whatever, but need to do that because that's the only way out. Because this pandemic, I think, has exposed a lot of weaknesses and a lot of way in terms of how we can respond to those weaknesses that have been highlighted by this small little virus that we can't even see. You know, right? I just want to rebut on one particular point that Dr. Shah and Dr. Mahfiz has spoken about. The function of the UCC. Now, again, the Unified Command Center is something that is very, I mean, it feels very vague to me. And I feel that that particular center has got more things to do. Like you all mentioned about ICU Command Center. We can also use that particular center to actually divert non-COVID patients to private hospitals or whatnot, you know, make them as the central coordinating arm. Your thoughts, Dr. Shah and Mahfiz?
Maybe Mahfiz go first.
Okay. Yes. Guna, thank you. Yeah. I would. The idea is there. Yeah. We can see in terms of when we plan, the UCC is there. Okay, fine. But that is currently, I think, not within what we can do. Of course, we can suggest as such because I think it can be more effective. And you are right. The UCC is there to just about COVID, but in terms of the diverting or channeling where to utilize your resources, I think this is important. Hence why I'm proposing, of course you say, oh, you buat lagi satu baru. No. I think we should take charge. ICU. Currently, even if you look at in public of who refer to in terms of we talk about ICU care and apa semua, we are not clear though. We're doing our personal calls. I get calls even though I'm not the expert, I'm not intensivist. I get calls as well, and how to manage and etc. So that particular in terms of ICU Command Central is there. The policy stage and the direction of what we're going and what we do. I think we're talking about critical care and what we are bound to do. I think that would be my point. Fair enough. But then again lah, who, of course kita akan tanya siapa yang nak buat ni, siapa yang nak buat, suruh boleh. I reckon if the direction is there straight away, okay, ICU, fraternity or currently in terms of the service in MOH, collaborate and do and destructure up now. From our side, like what I proposed earlier, a clinical consultative. So it's clear in terms of we can discuss. I learn a lot in the mornings during our the morning rounds. Yeah, but my morning rounds in COVID different. COVID management, as I mentioned earlier, how when we manage them, especially in ICU, is totally different from what we learn how to do it. Okay, we unlearn it basically. We learn to unlearn. We don't touch our patients. We use numbers. Those are our measures. Kalau kita belajar clinical tu macam boleh fail straight kalau jawab macam tu. But COVID is opposite. That's how we manage it in terms of reducing contact. The concept of minimalizing your contact with the patient. So these are the things I reckon we need direction, and if possible ASAP. I applaud the Society of Intensive Care with their recent active knowledge sharing, which I think is very benefit to all of us in the critical care in ICU managing patient. Shah?
Probably just to add 1 or 2 points. I think another issue is that the plan B, plan C, I mean, sincerely, I hope that we can manage to flatten the curve, and then there's no need for, all this, the thing that we have discussed. But I think if we are going in that, R value of 1.1, and probably if we're getting about, 8,000-9,000 cases per day, it's gonna spill over. And I think another direction that the UCC can become, or not just UCC, the consultative console, is also to outline what's the plan C, plan D at the local level. At the hospital. Okay, if we are overwhelmed, how do we utilize? This is also not just for private, but also for the public. Because when I was even in hospital in Kluang, you see that particularly the surgical specialties are not doing anything much. So there can be an element of how to roster people, what they can do to actually help in terms of in the ICU and so on and so forth. So I think it's also not just the supra level or the macro level, but also the micro level. I think the UCC can be the source, the guidance, so to speak, during this pandemic, if we go down that direction. That's it.
Okay, I think we go to QA session. There's 2 questions actually, but then one question already answered by Dr. Gunalan. The question is, our government doing the right way in reducing the number of COVID cases in the country? This is the basis of what has happened in our country till today. We can support as much as we could, but sooner the resources will be exhausted and the cases still rising. Think about it. So anyone can answer, or you want to answer?
I just give some numbers kejap for that to reply. Yesterday 305 in ICU and also 139, the highest ever kita intubate. Alright. Next.
So yeah, I mean, if you ask me, honestly speaking, is the government doing the right thing? I think the answer is quite clear that from what it was in second wave and what is it right now, there are probably some things that is a lot of missteps has been taking place. Now, at this present moment in time, I think we have to be led by the generals who are leading us at the moment. Okay, I think at the end of the day, whenever we are in a war, to be honest with you, we may have differing opinions, public, private, and whatnot, but we have to still be hopefully led by the generals who are actually doing some work. Now, the question is whether are they doing the right thing? I think we have to take that with a pinch of salt. There are some challenges here. There are some missteps, mismanagement, and whatnot in terms of the plans and the SOPs and everything. But I am more confident with the medical leadership, especially that is in KKM, outside of KKM, all those guys that are there, they are trying to do a fantastic job in very difficult circumstances. There are a lot of political pressure on every angle, everywhere they look, they're being pushed aside, opinions are not taken into account. There are also other well-meaning individuals from outside the public sector who are giving a lot of good and constructive opinion. But these opinions need to be taken into account. It's been almost 3 weeks, I think, since we last heard the Prime Minister declaring, hey, I would love to hear your thoughts. Let's form a panel of experts and let us work together with the Ministry of Health, and let's see how we can take it moving forward. Until today, I've yet to see a significant move towards that forming of the panel. And these things are what worries me, because it's been 3 weeks. We don't have the luxury of 3 weeks to decide these things. This has to be like 24 hours, 48 hours. Let's just get the ball running. The funding was announced like 2 weeks ago. How many patients have I seen in non-COVID hospitals managing a non-COVID case? Nothing at the moment. There are patients in my ICU who are paying out of their pocket, and it's the bills are actually growing above unbelievable amount of money because they've been there. And what do I tell them? What do we communicate to these patients? Again, it's unclear at the moment. So we do not have the luxury of time. I think that part of it is clear. We do not have the luxury of time. So we need to get our act together. Once the vaccination, hopefully the numbers will be down, but we have this next few weeks to get our act right, and hopefully we'll come out of it.
Maybe I can just add a bit now. Somebody wrote here, actually, there's a black van waiting for me outside. Now, if I happen,
police.
To all my colleagues in Prince Court, for the next 1 week, if you don't see me, it's not that I'm on leave,
Black Maria.
Jangan cari dekat Hospital Sungai Buloh, but dekat sebenarnya penjara Sungai Buloh. Okay, find me. Okay, now whether the government is doing a good job or not if you have to look at the numbers. It speaks for themselves. The increasing numbers there, the mortality rate increasing. You're right to say that we at the medical part of this pandemic, we're doing the best that we can. And I think we're doing a great job, because looking at only 1.4% mortality, that speaks volumes of how good we are in terms of managing COVID-19 patients. But that is only one aspect of medical. Don't forget the non-COVID. Do you know that the number of dengue deaths has increased over the last 6 months? The so-called patients dying from heart attacks have increased. Oncology patients are not getting the treatment that they're supposed to be getting. A lot of confusion here and there. We are handling something that is, we're not looking at the bigger picture here. We're very focused. We're very focus orientated now on COVID-19, that we're missing a lot of a big chunk of our healthcare is being redirected in terms of managing something that is only, where our part is only one small part. The bigger part, the 80% of it, where we're supposed to reduce the numbers, that I feel is lacking, where there's a lack of leadership, whether we don't have proper guidelines, or whether we don't have a proper approach. I doubt that is it. I think we do have the plan. I think we do have it. Come on, we had 1 year of doing COVID-19. Don't tell me sampai sekarang we don't have a plan in place. That's ridiculous. If that is the case, then everyone from the top down must resign. If they have not had the plan is there. It's just that it's not being implemented in the right way. That's all I can see. Whether it's political interference, whether it's economical interference, whether what is it, it's not for us to say, but we are looking only at the result of all these things. So coming back to the question, is our government doing the right thing? You see for yourself. Do you see the numbers coming down? Do you see the death rate coming down? You can answer it yourself, Tak nampak, kesian.
Any more? I think the time is not in our side.
I think I just take one last question. I think Dr. Bachchan has mentioned here. Ethically, is it fair to assume elderly private doctors with or without comorbidities to be in the private line? I think it's a very personal choice. If you ask me, if you feel strongly that you have significant comorbidities and you are putting yourself at risk to get infection and COVID, and that concerns you, I think you have the right to say, no, I do not want to be involved. But this is an individualized decision, because I think at the end of the day, you know what is best for you. Because I think whatever said and done, I think nobody can put a gun to your head and say, you have cancer, can you just go and manage a COVID-19 patient? I don't think nobody would do that. I don't think it's fair for any private hospital or any kind of organization or bodies to force that on down to you. But I refrain from commenting further, because I think individual private hospitals will have your own quirks in terms of how you're dealing with your contracts and whatnot. So I hope the private hospital management will be a bit more receptive to the idea that, look, there is a slight possibility of issues whenever we have elderly doctors handling patients with their COVID, and hope that this is something that they will take into account.
being a elderly doctor, I think as a senior doctor, I think you're right. Again, it's individually choice, but sometimes we don't have the luxury in our own hospital. It's you look at it. It's sometimes I feel it's not fair. Like just now you also Dr. Nana at the start of just before we went on air. I mean, she's there also in the front line. She's also, I mean, can you imagine nanti if she, God forbid, develop COVID-19 infection, who's going to take care of the punya pokok-pokok keladi nanti, That's a huge investment there. So I mean, again, it's a matter of choice. I and Dr. Anu being the two senior ones in Prince Court, we do our part, we do our share. And I think with the right protection that has been provided by the hospital, that's good. We have all the equipments and everything, and we're quite confident when we actually go to see our patients, that we're well protected. Of course, fatigue-wise, yeah, sometimes it gets a bit tiring. But we take it as part of our duty. We do it not because we have to, but because we want to. Okay, there's a different look at it. Okay.
Yep, and I also believe that despite having, say, for example, I mean, maybe you are talking about physical deterrence or the risk, but there is always a role. The think tank, the whole management. And it depends on your hospital setup. Certain things physically may not be wise for them to be exposed, but of course there is the mind that wise, the knowledge or the understanding, that sharing and to co-manage together in giving. So I think there's a role. There's a role in the management, not directly managing, as in per se physically to intubate. Maybe that can be a sort of like a too risky, etc. Because there can be always somebody, but again, the planning of how to do. I guess like what Prof. Rozaidi shared earlier in terms of when we're intubating, that's why it's different in terms of even Code Blue. For COVID-19, the planning of to expect what to do have to be there. The planning must be available and being educated to your staff, etc. And that's how we handle it. So yeah, everybody have a role. So yeah, inshallah. I think we have been doing okay. The concerns by everybody, all anesthetists, intensivists, young and senior, valid, and all these points should be taken into consideration, because we must work together in terms of protecting our ecosystem and fraternity. Because at the end of the day, we do not have anybody else to depend to as the last line of defense.
Orthopedic surgeon ada.
They have a role too. They have a role. I have roles for them. If I'm the DG, you give me, I have my roles.
Okay. I think no more questions here. I think no more questions. Any last take-home message from all the panelists, which are equal to our summary for debate today? Yeah. Dr. Shah, start first. Your take-home message.
My take-home, I think, do what is right, not what is easy.
Yeah, my take-home would be, we are all in this together. It is not about private or public. At the end of the day, we all have a role to play. But most importantly, let's safeguard each other. At the end of the day, MSA, AGM, ASC, we are still having it on an annual basis. We all want to see each other in the meetings. We still want to talk to each other. We still want to have our annual gala dinners, talk to each other. So let's hope in a couple of months' time, we can look back at this moment and say we passed this and we have succeeded and we work together as a team. All right? That's the main thing. We are one team here.
Okay, Dr. Mafid.
I mean, bring it on. But at the same time, do this together. Let's do this together.
Dr. Syed or the Prof. Syed?
No more Prof. Okay. Take-home message. Well, I think everyone has said the right thing, and we'll do our best. If anything, once the MCO are lifted, you're more than welcome to come to my restaurant, and we can have another chit chat and minum kopi and other things. Let's stop talking about COVID. Penat dah. There are a lot more things that we can talk about. Okay.
Okay. So that is a conclude our debate, or rather our discussion with a different opinion. And then thank you for attending. See you all next time. Bye.
Thank you. Bye.
Thank you, everyone.
Assalamualaikum.
Bye.
Bye. Have a good Sunday. Bye.
Yep.
Thank you.